So the next vital sign here is temperature. And your temperature, even though the average normal is 98.6, that can vary from person to person, and it could also depend on a couple of other things like the time of day, their activity level, age, how are you measuring it. So the most common way that we are probably going to see it measured in the field is going to be tympanic, which is through the ear. You might also see it taken orally through the mouth. And rectal is going to be the most accurate reflection, especially for infants. So if you have an infant or you have someone with a heat-related emergency or maybe a resuscitated cardiac arrest and you have the ability to check a rectal temperature, you really want to utilize that because it's going to be a lot more effective for you. Any temperature that's over 100.4 is considered feverish or febrile and is probably going to need some type of treatment based off of the North Carolina State protocol. All right, so if it's 100.4 or higher, then you're probably going to be treating that. Now, looking at SpO2, this is a very unique tool, and it's one that's used on a lot of EMS calls, but it can only tell you so much. And so I'm going to bust up some of those myths related to SpO2 and tell you what's normal and what's not. So your oxygen saturation, or SpO2, which is going to be measured using a pulse oximeter, what it's actually doing is measuring how saturated is the hemoglobin in your blood, right? So remember, your red blood cells have hemoglobin, and your oxygen is going to bind to that, but other things can bind to it. So CO, CO2, chlorine gas, other things can displace oxygen from there. So what this is telling you is not how much oxygen it is there, it's telling you how saturated the hemoglobin is. So it can actually give you some false readings. You could see that a patient has an SpO2 of 100%, but it doesn't tell you that it is 100% oxygen. It very well could be CO or CO2 or anything else I just said. So we want to be very cautious here not to rely solely on what we see and actually treat the patient and not the monitor. So certainly if the patient is having difficulty breathing, even if our SpO2 looks good, we still want to provide treatment for the patient. So we also want to consider other things that can affect your SpO2 reading, like your perfusion. If you're not getting good blood flow or good circulation all the way out to your fingertips, then you're not going to get a good reading here. Other things like nail polish or acrylic fingernails, if they're very cold, those things can all alter your SpO2 reading as well. So just be very careful when you're checking this. Now, if you're getting a good reading, then what's considered normal is between 94 and 100%. The whole goal here is not to necessarily be at 100%. It's just to, what's normal for the patient. So we'll get into that a little bit more. Mild hypoxia would be a range of about 94 down to 85%, and less than that would be really severe. Now, I'm going to jump back to SpO2 for a quick second. Things that can alter your SpO2 reading are chronic illnesses like COPD. So if you have someone with COPD, generally they're probably always, all the time, walking around with a much lower SpO2 and a much higher Untitled, which we're getting ready to talk about. And so if that's what's normal for them and they're not having any complaints with their breathing and you're not concerned about that, then don't feel like you have to give them oxygen or treat them for some potential hypoxia just based off of this reading alone. All right, we want to treat the patient and not just the monitor. But on the back side of that, if you have a good SpO2 reading and the patient seems to really be struggling, still go ahead and give some oxygen. What we don't want to do is knock out the hypoxic drive. And so that means basically that if you and I are breathing normally, if our SpO2 was truly low and our Untitled was truly high, then we would probably have an altered mental status. But these patients who have learned to operate at these normal levels, and that's what's normal for them every day, they have the exact opposite effect. And so if you actually give them too much oxygen, they would become confused, have an altered mental status, and maybe even become unresponsive. And we need to not knock out that hypoxic drive. So Untitled is a much more reliable tool than SpO2, and it's really finding its way in pre-hospital medicine. We're using this a lot more frequently than we used to for a lot of different things. So you can hear this referred to as end-tidal or ETCO2 or capnography or capnometry. And so let's talk about what those terms mean. This is usually measured with an ECG monitor. That's why you see several different numbers here on this particular screen. The number and the waveform that we're looking at here are going to be that yellow. That's actually what we're measuring here with end-tidal. So the two different terms, capnometry is related to the number. So that 36 that you see there on the screen, that would be normal, because between 35 and 45 millimeters of mercury is normal for capnometry, and that's the number. Now capnography is the the graph. So you see those yellow plateaus there on the screen. That's the capnography or the waveform that you're going to see. So even though you might hear those terms used synonymously, if somebody says capnography, they're probably asking for both the number and the waveform. I just want to make sure you understand the difference between the two for testing purposes. Now, how do we measure that? We're going to use some type of device, like we said, most likely hooked up to a cardiac monitor. So those first two things that you see here on the screen, those both with those orange adapters plug into a cardiac monitor. The first one attaches directly to a tube. So if you have an advanced airway in place, or it can fit between the mask and the bag of the BVM, that's how you would use that. The other one is going to tell you the exact same information, but we call that side stream. And so that's when the patient is breathing in and out of their nose, and so it only works if they're breathing in and out of their nose that you're going to get a good reading here, but it's measuring what they're exhaling. Okay, so again, for both of these, they plug directly into the monitor, and they are going to give you that information, that waveform and the number. And these are really important to use for any patient that's having respiratory issues. If you're putting an advanced airway or tube in place, it is the best method of tube confirmation and is required by Office of EMS to use these. With the side stream, you can give oxygen just like you could with a traditional nasal cannula. So just making sure that you're familiar with the equipment. Now, less likely to be used, but is still out there on the market, and that's the easy cap or color change capnometry that you see there in the third picture. And so essentially this is a one-time use, whereas the other two can give you continuous monitoring and continuous feedback on your patient's breathing and their status. That's going to be a one-time use, usually used for tube confirmation, that hopefully it would change from purple to gold. Gold is good, so it should change from from purple to gold or yellow. And if it is, then that means your tube's in the right spot. But again, it could move, it could become dislodged, it could be other issues. So really continuous monitoring with the other methods are going to be your best bet. Now, looking at the waveform of the capnography itself, we said normal as far as number is between 35 and 45, and normal waveform looks like what you see up there on the top. So that plateau, that's normal. Down here on the bottom, you see that you've got a kind of a loss of that plateau. Those are what we call shark fin waveforms, and that means that the end-tidal is higher than 45, and this comes from air trapping. So someone who is having those bronchospasms or air that is stuck inside of those alveoli and not being able to make an exchange, that's generally where we see that. If they do have an end-tidal that is less than 35, they could still present with the plateau. The plateau is just going to be shorter, all right? And so the way that this actually works is that it's measuring your exhalation. So it's looking at the actual exhalation period. And so what you see right here, and I'll try to do it with my mouse, is that this is where you start exhaling. So down here, this is your inhale. And as you exhale, it rises and it reaches a peak. And that's the peak. And then as you breathe in and inhale again, this drops down. So it's actually the opposite of what you would expect as far as if you expect to see inhale, it rises up. No, it's the opposite because it's measuring your exhalation here. Okay. So things that could alter your end-tidal, either higher or lower. If it's higher than 45, you might suspect something like asthma or COPD. Again, is that chronic? Is that normal for them? or are they having an active attack now? Are they having some type of other dyspnea or difficulty breathing? And also when the patient is in cardiac arrest, if you get a pulse back, which we would call return of spontaneous circulation or ROSC, you might see a sudden spike above 45 because the normal end tidal during a cardiac arrest is around 10. So you might see that jump up. Now, down here at the bottom, it's talking about patients who have lower than normal as end tidal or ETCO2, so less than 35. Things that can cause that are hyperventilation, alkalotic issues from pH imbalance, sepsis, and then, like we said, the cardiac arrest. So end tidal can tell us a whole lot about what's going on with the patient, so it's a really good tool. Now, if you have this on the patient and they've been maintaining a normal end tidal, let's say you're ventilating with a BVM and their end tidal has been between 35 and 45 the whole time, but now you see a change in it, it might be something that you're doing. So you might need to alter your ventilation pattern. So if it is higher than 45, you need to blow more CO2 off so you would ventilate faster. And if it's lower than 35 and you're ventilating, you want to ventilate slower to let more CO2 build up. Okay, so if it's high, let it fly. And if it's low, do it slow. All right, so just keep that in mind. Now, blood glucose, again, we'll go through this step by step when you're here on campus with me, talking about how we can measure blood sugar step by step. But essentially what the glucometer is going to tell us is that blood sugar. And so not everyone who knows that they have, so everyone might not know that they have issues with their blood sugar, or someone who is not a diabetic could still be experiencing a low blood sugar or even a high blood sugar maybe. And so these are essential to check on virtually every patient, but especially patients that have an altered mental status or feeling dizzy or lightheaded. And so we'll use that glucometer to do this. Now it's calibrated to specific capillary blood at the fingertips, so you want to be very cautious about that and make sure you're getting it from the correct place. These are the step-by-step instructions for that blood glucose measurement. And again, we'll go through all of this when you're here on campus with me. The most important thing I want to emphasize is to wipe away that first drop of blood so that there's any alcohol residue. It doesn't give you a false reading because alcohol can turn to sugar in the blood. So normal blood glucose results are going to be between 80 and 120, but again, that's going to vary person to person. So generally we consider hypoglycemia where we start receiving treatment around 60, and hyper or too high glycemia where we would start receiving treatment to bring it down at around 250. But again, all of this is patient dependent because what's normal for one person might not be normal for someone else. Their blood sugar could be consistently higher or lower, and that's what's normal for them. Maybe they're not feeling bad, and so we just make note of it and move on. Doesn't necessarily require treatment unless they're having symptoms. This chart here, again, just breaking some of that down and telling you what's considered normal and abnormal, but also things that could be influencing blood glucose, like the patient history, medications that they're taking, illness, stress, last oral intake, any nausea, vomiting, diarrhea. All of these things can drastically influence a patient's blood sugar. And then level of consciousness, we talked about this during patient assessment, so I'm not going to harp on this, but it is considered a vital sign. So using the AVPU scale and assessing for orientation to see if the patient is alert and oriented ×4. And then again, remembering that for all of these vital signs, we need to know what's normal for the patient so that we can know what's abnormal for them as well. So taking into account their own medical history, situational events, their age, things of that nature. So again, not one set of bad vital signs is not as bad as a negative trending set. That means the patient is deteriorating. So we want to keep an eye on that during our reassessment phase.